Good afternoon. I'm Kim Hee-jung from Asan Hospital, Asan Medical Center. Today, under the title Young Blossoms, Different Blooms, Exploring Breast Cancer in Young Women, I will talk about the survival and multidisciplinary approach in young women with breast cancer, as well as future studies of young women with breast cancer. Research on age and breast cancer survival rates has been ongoing for a long time, and even in the most recent study using SEER data, the recurrence rate of women under 40 years old at diagnosis is higher than that of other age groups. This is likely because they have not reached the age for routine breast cancer screening, leading to delayed detection at more advanced stages, or because they have higher proliferative rate estrogen receptor negative or HER2 positive cancer. We can think about whether the prognosis of treatment will be different even under the same conditions. In the past, younger patients received more chemotherapy because their prognosis was slightly worse. First, according to data from the Korean Breast Cancer Society database, there is no difference in survival rates by age in hormone receptor negative cancer on the left, but in hormone receptor positive cancer on the right, the survival rate is lower in those under 35 years old, indicated in blue. According to the US SEER database, there is no difference in survival rates by age in triple negative or HER2 positive types, but in hormone receptor positive HER2 negative breast cancer, the recurrence risk is about 1.73 times higher than other age groups, even after adjusting for all factors. Why is there such a difference in receptor positive cases? This study compared sequential and concurrent chemotherapy, and contrary to the initial hypothesis, the results showed that survival rates were better when amenorrhea was induced regardless of the method. If we think about it, the key to treating hormone receptor positive breast cancer is to suppress hormones well. And in young women, ovarian function easily returns after treatment compared to chemotherapy or other treatments. So the survival rate in hormone receptor positive types may be slightly lower than in other age groups. Therefore, when amenorrhea was induced, the survival rate was found to be good. So, if ovarian function returns, wouldn't adding ovarian function suppression be better for the prognosis? With this hypothesis, additional studies on ovarian function suppression started in Europe and Korea, and the results have been published since 2014. First, the SOFT study, which started in Europe, compared tamoxifen alone and tamoxifen with ovarian function suppression and aromatase inhibitors with ovarian function suppression over 5 years, and recently published 12-year results. When ovarian function suppression, or OFS, was added to tamoxifen, the recurrence rate decreased by 4.2%, and when added to aromatase inhibitors, it decreased by 7.1%. In a group that showed better effectiveness, the effect was better in patients who had previously received neoadjuvant chemotherapy and those under 35 years old with high proliferative cancer. The ASTRA study, which started in Korea, was a study that added ovarian function suppression to tamoxifen for 2 years after chemotherapy in patients under 45 years of age when ovarian function was restored. The difference from the SOFT study is the duration of ovarian function suppression treatment. The ASTRA study had a treatment period of 2 years, while the SOFT study had a treatment period of 5 years. Compared to tamoxifen alone, the addition of ovarian function suppression showed a reduction in recurrence rate of about 5% after 5 years of follow-up. Based on the results of SOFT and ASTRA studies, when ovarian function was restored after chemotherapy, the addition of ovarian function suppression helped improve survival rates for a minimum of 2 to 5 years. This ASTRA study was specified in the treatment duration in the 2024 American Breast Cancer's NCCN guidelines. Compared to the previous recommendation of only 5 years, it was changed to recommend a minimum of 2 years of OFS. allowing for treatment to be selected appropriately according to the situation. Then, when to start OFS after chemotherapy? The TEC study started simultaneously with chemotherapy. The SOFT study started at 6 to 8 months, and the ASTRA study observed the recovery of ovarian function and added ovarian function suppression when the function was recovered, with an observation period of about 2 years. Comparing the TEX and SOFT studies, there was no difference in survival rates, so it can be seen that there is no difference between starting concurrently with chemotherapy or immediately after treatment. If it's a 45-year-old or a 49-year-old woman, perhaps menopause may occur or menstruation may return late after chemotherapy. So whether it's appropriate to do it for 5 years can be found in the ASTRA study. In fact, the ASTRA study comparing the recovery of ovarian function after chemotherapy showed that a 36-year-old woman's ovarian function is restored about 6 times more than a 45-year-old woman's ovarian function recovery. Based on the results, a prediction model for menstruation recovery was created. The patient's age, type of chemotherapy, and duration of chemotherapy were the most important factors, and through this model, the probability of ovarian function restoration can be predicted. For example, if a 41-year-old woman received AC chemotherapy for 3 months, it would be 4 points, and the probability of ovarian function recovery within 1 year is 39%, and 3 years is 70%. For 36-year-old women, it is 6 points, and the probability of returning within 3 years is 95%. For a 48-year-old woman, it is 2 points, and the probability of returning within 3 years is 40%. So predicting this ovarian function recovery and considering the administration of OFS accordingly may be a good approach. In summary, depending on the patient's age and breast cancer risk, hormone therapy and hormone receptor positive, HER2 negative breast cancer can be categorized. In high-risk cases, OFS and aromatase inhibitors. In moderate or lower-risk breast cancer, OFS and tamoxifen. And for women diagnosed with very low-risk breast cancer in their mid-40s or later, tamoxifen alone can also be considered. Many studies and data analysis are currently being conducted on whether tamoxifen alone can be considered in young patients with low risk. In cases where chemotherapy is given, ovarian function suppression can be used for the purpose of ovarian protection. Multidisciplinary treatment should consider various things that may arise along with a treatment plan for breast cancer, especially fertility preservation or ovarian dysfunction in advance, and comprehensively consider future pregnancy, parenting, survivorship, and various conditions for receiving good breast cancer treatment, long-term complications, and quality of life. First, adherence with protocol. In the SOFT study, about 18 to 23% of patients discontinued treatment within 5 years, and in the ASTRA study, it was about 26%. In fact, patients are having a hard time due to hot flushes, sweats, vagina dryness caused by hormonal therapy, and it is not easy to get ovarian suppression injections in the abdomen every time. This graph is data from Seoul as a medical center, and the pink graph is the actual number of patients by age. It shows the characteristics of breast cancer patients in Korea and Asia, where there are many patients in their late 40s and early 50s. And the mint colored line is the actual number of days the patient did not pick up the medication. Compared to patients in their 40s and 50s who actively adhere to protocol on average, the adherence to protocol is somewhat lower lower for patients who are younger or older than 70 years old. Adherence to protocol is actually related to the recurrence rate to some extent, so those who did not take the medication will show a slightly higher recurrence rate compared to other groups. So I think that adhering to protocol as much as possible will actually help improve survival rates. In summary, the relatively poor prognosis of young women is observed in hormone receptor positive breast cancer, and in the past, chemotherapy was often performed, but inducing amenorrhea was actually helpful in improving survival rates. So, additional studies on OFS began, and its effectiveness was recognized. However, the other side of this long term amenorrhea inducing treatment is ovarian dysfunction and decreased fertility. Therefore, we need to be prepared, especially patients who want to get pregnant should be prepared. And fortunately, the prognosis of fertility preservation procedures, OFS, during chemotherapy, pregnancy after breast cancer, and most recently, pregnancy after interrupting endocrine treatment, have shown no significant difference compared to patients who did not receive them. Of course, some degree of bias may be reflected, as such a study cannot be deliberately planned. So, for patients who want to become pregnant, it will be important to prepare actively in advance and to have sufficient consultation with medical staff during the preparation process for pregnancy. Such fertility preservation includes ovarian function suppression that prevent the destruction of ovarian tissue during chemotherapy, and more active methods such as oocyte embryo and ovarian tissue cryopreservation. During chemotherapy, OFS have been reported to actually reduce ovarian dysfunction by more than half and increase pregnancy rates by more than twice. So it is recommended to consider it more actively during chemotherapy. As a medical center operates a multidisciplinary clinic together with the Department of Surgery, Internal Medicine, Fertility Preservation Specialists, Obstetrics, and Gynecology and Radiology. Educational materials were produced and changes in knowledge before and after the educational materials were compared. In fact, 57% of patients answered that they did not know the breast cancer treatment could cause ovarian dysfunction or difficulty in pregnancy. And after reading the educational materials, many people had a better understanding. Educational materials such as those below were distributed, and when asked if they had any intention of OFS, oocyte, or embryo cryopreservation for fertility preservation and ovarian function maintenance, 40 to 44% of patients answered yes. However, 44% said they would not do it if treatment was delayed, and about 33% said they would have it for about 1 to 2 weeks. So it was found that it is important to create a program and system that can provide sufficient consultation and prepare for this while minimizing treatment delays. In addition, there was a study comparing bone mineral density over 5 years of treatment in premenopausal women. Patients receiving chemotherapy or OFS showed significantly lower bone density compared to patients who did not receive any treatment. And this bone density decrease was significant in the first year of starting treatment and continued for about 5 years. So regular observation and education on lifestyle modifications are very important. This study is very interesting. It's a survey on the quality of life of patients receiving chemotherapy and hormone therapy. The results were slightly different from what we had expected. The patient group shown in orange is the chemotherapy group, and when asked if they had ever been upset due to hair loss, surprisingly, there were few patients in the chemotherapy group who answered yes, while there were many patients in the hormone therapy group who answered yes. The reason is that patients receiving chemotherapy are aware of hair loss and are already prepared to some extent, while patients receiving hormone therapy do not actually experience complete baldness, but some hair loss may occur, and they were not informed of this in advance and were not prepared, so they were more likely to get upset. So, if patients are sufficiently explained and informed, and if they understand well and prepare for the things that may arise due to treatment, patients will be able to overcome this process better. In addition, there are many concerns among breast cancer patients with young children about whether they should tell them about the diagnosis and whether the process they go through due to treatment will affect the children's emotional development. The details of this will be explained in detail by Professor Kim Yu-won in the next session. Breast cancer diagnosis is not related to children's emotional development, so it is important to get treated, and patients do not need to feel guilty. Korea and Asia have recently been leading the treatment of breast cancer. And I think the treatment is well advanced more than anywhere else. However, the system to help with counseling is actually lacking. Even for fertility preservation counseling, patients have fears about breast cancer and treatment delays, and it is not easy to make a decision because they uh, have not thought about such things in the past. And from the doctor's point of view, the outpatient clinic is too busy, and most of their time is spent on treating breast cancer, which leaves little time for effective consultation. And there are hospitals without a multidisciplinary team, so effective counseling is not easy in reality. In Korea, a cohort study called Multidisciplinary Shared Decision Making for Fertility Preservation in Young Breast Cancer Patients has been started. And it is a study comparing the usual care group and the shared decision making group, and a systematic counseling program will be developed through this study. The results of the study are expected to raise awareness of the importance of such counseling programs. And based on these results, it is planned to recommend medical policies or insurance coverage for such fertility preservation procedures. Research on young breast cancer is a comprehensive complex of research that improves survival rates, translational research, medical complications, and survivorship research to maintain patients' quality of life. In conclusion, as of 2024, disparities remain in survival rates for young breast cancer patients, especially those with hormone receptor positive breast cancer. However, it is expected that this difference will gradually decrease with the additional treatment of OFS. In particular, minimizing and helping young patients overcome the various things that may arise due to treatment will not only improve the patient's quality of life, but also actually increase survival rates as a result of receiving good treatment. Clinical research that leads to building good systems and policies may not change our medical policies right away, but I think it will be an opportunity to change future medical policies and treatment. Optimal treatment of young women should be personalized according to their preferences, age, adherence to protocols, and future pregnancy plans. Thank you for listening.